I was
Okay.
just trying to find the slides.
Okay, so if you go to the Google Drive, if I shared the file with you, it'll say like nursing 1120 flashcard something. And let me do this. Let me bring that up, and I'll walk through that on the app on the Google Hangout. So I'm kind of walking it with you. So go to this is kind of nice when it's just you and I, because you can see how I think and how I set this up. Okay, so yeah, it's under my school file. So it's called NURS 1120, which is it probably should be 1130. I just haven't changed it. I'm lazy. FC PowerPoints, and then the way I built this is each exam 1, 2, 3, and 4 have a file for them. So like obviously we've done exams 1, 2, 3, and 4. So those are the previous units, and I just kind of put those away. And then exam 4 is where we're currently at. Click on exam 4. It'll say unit 9 endocrine, unit 10 neuro, and last week was unit 9. So click on unit 10, and there are 2 files in there. One that says student files and one that says class files. The class files are the things that Tana and Megan sent out to us on Canvas. I just download them here for ease. Like they're here. We don't have to go anywhere else to get them. If we ever need something from there, we can just pull it up. And then the student files are the stuff that any of us generate. So like right now, it's just the stuff that I generated, a unit 10 PowerPoints in there. So click on student file. There's only one PowerPoint in there.
Okay, I found it.
So go ahead and click on it, and it should bring it up for you. And then you and I will be on the same PowerPoint. And then in addition, to you can be following me on your computer, and if you get lost, at least you can click forward as we're talking through it, and we can say the same stuff.
Okay.
And then we're not lost. Then we're together, as opposed to being lost, and that's not very much fun because you're like, "What's he talking about?" Okay, so if you're there, the slides coming up.
Yep, I got them up.
Okay, so if you go to PowerPoint and just bring them up on PowerPoint, that's where I'm at. And the first slide just says Unit 1, Disease and Cellular Response, which was the name of the unit. And then it's just a review. So there's a review of inflammation. And so starting with like acute on the left side, we'll go across there. So one of the things I like about the way that I set this up, I used Tana and Megan's their stuff from the lecture, from the notes to set this up. And so now it's clearly visible that acute, as you look across the acute column, what is the phrase that keeps coming up? It's true for local and systemic.
I don't know.
So looking at the very top line, it says expected to resolve under local and expected to resolve under systemic. So under acute, acute is always expected to resolve on its own. Well, then going down to chronic, now that you kind of know what I'm looking at, under chronic, what is the phrase that keeps coming up that's the same for both systemic and local? Chronic.
Hello.
Hey, what's up?
Okay.
Exacerbations and remissions.
Yeah, exacerbation. Hey, Zakia, how are you?
Good. How are you?
Good. Let me get the slides back up.
Okay, good.
So Ashley's on tonight. She's not participating in the studio audience.
Okay.
She's actually with us, and we're going through slide number 1, inflammation from Unit 1A, and we're just going through the key things that recur that are the same for each category. So we went through acute, and under acute, for local and systemic, it's expected to resolve. So acute injuries, inflammation patterns resolve on their own. Whether they're systemic or local, they just resolve on their own. And then under chronic, Ashley, what was the key thing for under chronic? What's the key phrase?
Exacerbations and remissions.
So what does that mean when exacerbation or remission?
I don't know how to explain it. It's like when it flares up and then you like go into remission and it calms down for a while.
Yeah, it flares up. With some treatment or the body's natural defenses kick in, it draws it back, and so the inflammation and the pain and the symptoms get diminished, and then they start to get worse again on their own. Like something can trigger it, whether it's an opportunistic infection, you overexert yourself, you expose to the pathogen, whatever it is, it brings and it comes back again. So that's what's going on with that. Okay. Where the heck?
Okay.
Okay, so we're still there?
Yep.
Yep.
Okay, so moving along. So now that you kind of know where I'm going mentally with that, look at local and tell me what's the same with local acute and local chronic injuries.
What's the same?
Yeah, what's the phrase that repeats in local as you move down from acute injury to chronic inflammation? What's the phrase that keeps recurring that's the same?
Sharp?
Yeah, so signs and symptoms of sharp. And what was sharp?
Swelling. Is it heat?
Yep, heat.
I don't know what A is.
Abnormal function.
And redness.
Yep.
I don't know P either.
Well, P's easy. P's pain.
Pain.
Oh, duh. Okay.
Swelling.
It's too easy. That's why I don't get it.
Altered function or altered
Yep.
movement. Redness and pain is sharp. And that's the same for local acute and local chronic injuries. Okay. What about systemic? What's the same for systemic?
Increased white blood cells,
Yep.
CRP, and fever.
Yep, those are all the same for acute systemic and chronic systemic. So I like that when I put this together this way, it seems a little bit easier because all you do is memorize that local has sharp and acute has expected to resolve. And so I can build them. I don't have to go, oh, what was acute systemic?
Yeah.
You know, acute always has expected to resolve. Just write that out. And systemic is elevated white blood cell, elevated CRP, and elevated fever.
So, just in the back to that slide. So we have just different type of white blood cells will be elevated. Like with the acute will be your neutrophils, and with the chronic will be your lymphocytes.
Yes. So yeah, as we get more detailed into this, that is true. In the acute inflammation, an acute systemic inflammation, it's going to be a neutrophil count on our CBCs that'll be elevated. And in our chronic systemic, it should be our lymphocyte, B and T cells that are going to be elevated.
Okay. And one more thing. So this is applied to our neurological system because we know like diabetes will be chronic, but there is no sharp signs and symptoms will be appear, right?
No, if it's diabetes and it's going to be chronic systemic, we're going to have bouts of exacerbation or remission with elevated immune response, white blood cells, CRP, and fever, and the kinds of injuries or the kinds of diseases that are chronic systemic are rheumatoid arthritis. Anything autoimmune is going to be chronic systemic. Arteriosclerosis or plaque buildup on the walls of our blood vessels, diabetes, as you mentioned just a minute ago, hepatitis, which is that swelling of the liver with damaged hepatocytes, and then obviously elevated lymphocytes is going to be a clear sign and symptom that they're in chronic systemic inflammation.
Okay, great.
That's a review. Everybody ready to move forward?
Yeah.
Yep.
Okay, so that was just a good review that, hey, we've seen it again. Anytime we review these previous sections, it's nice because it kind of sparks our memory. We know what this stuff says, but sometimes we get a little bit far away from it in class, focusing on the current unit, and we kind of lose track of some of this stuff. And so that's why I'm adding these slides back in.
And then they throw it on our quiz, and we're like, oh.
And then they throw it on a damn quiz, and it's a little bit fuzzy, and you miss it, and it pisses you off.
Yeah.
So that's why I do some of this, because I hate missing questions on, I almost said the nasty word, on stuff that we already know, that and it makes you mad because instead of getting a 12 out of 10, you got an 11 out of 10 because of a stupid question that you already should know and you just forgot because you haven't looked at it in a couple of weeks. That's really damn frustrating, and I hate that.
Yeah, me too.
And you'll get nobody who gets more pissed off about that than me.
Oh, okay.
I promise. I'm like the meanest person in the world for that. Okay, are you guys seeing the second slide, Unit 1 Bravo, Neoplasm and Genetic Review on your screens?
Yeah.
Can you see it?
Wait.
It should say Unit 1 Bravo, Neoplasm and Genetic Review.
I can see it.
Ashley can see it.
Yes, I can. Sorry.
So as you can see, ladies, there is 2 columns there, one specifically dealing with benign tumors and one dealing with malignant tumors. And we're going to go through the different characteristics. So when we talk about cell characteristics between benign and malignant tumors, can either one of you remember what we call those cells?
No.
Okay, if you need some help, I'll give you some help. Say, I need a lifeline, and I'll give you a lifeline. So somebody say, I need a lifeline. Am I not going to get a lifeline call?
Just a second. So cell characteristic. So those are characteristic of cancerous cells?
Yes.
Is that what
cancerous cells?
Okay. So what was your question?
The question is, the first line says cell characteristics of benign and malignant tumor cells. How would we describe those tumor cells to a doctor or another nurse to tell them it's benign or it's malignant?
Oh, okay.
Learning Commons.
So for benign, it will not be movable. No. Yeah. So for malignant will metastasize. That's the one that I remember.
Okay. So metastasis is down a little lower. So the second one from the bottom is metastasis.
Oh, okay. I see. So you need cell characteristic. Okay. They lack cohesiveness.
Cohesion is, it says cell. It talks about cellular cohesion is the second line. So what I'm looking for is there's a word that starts with D. It's
differentiation
and not differentiated. So yes, Ashley, you're there with me now.
Yeah.
So
Okay.
the word we're looking for is differentiated and non-differentiated. So which type of cells, benign or malignant, are differentiated and which are not differentiated? So I just removed the first box. Can you guys see that I removed it?
Nope.
No.
Damn this thing. I hate you. Okay, there we go. Can you see it now?
Nope. So cell characteristic. Okay.
This is what happens when I try to do something nice.
Okay, so benign will be differentiated and the malignant will be undifferentiated.
Mm-hmm.
Yep, you're on the team now. So let me click these off on my side so when I bring this back up, you guys can see all the answers. And that's not as good a way of reviewing, but let's get through this and it'll hustle it up.
Let's see. Let's just say it and then you can post it. Let's just go through it like that. And then you can reveal all of them.
Why is this not working? Okay, I cleared them all off. And let's see what's here now. Stop sharing it, everybody. Okay, I don't know what the hell's going on with this. Okay, here we go. Here we go, ladies. I'm just going to read them out for you.
Okay.
Okay, so I'm going to go through all the benign tumor stuff first, and I'll go through the malignant stuff second. So cell characteristics of a benign tumor are well differentiated. So if benign tumors are well differentiated, then what are malignant tumors?
Undifferentiated or
they're poorly differentiated.
Poorly. Okay.
Okay. So benign tumors, when you look at them through the microscope, or you look at them when they're in the body, they're going to be like one color. They're going to be all together with the cell capsule around them or a tumor capsule around them, and they're going to look not offending, right? It looks like, hey, I could just get a spoon and scoop those out, no problem. Malignant tumor get that black, nasty star shape, and they want to innervate and invade other cells around them, and they change color. They look nasty. They don't look normal.
Really?
Yeah. When you look at them through the microscope, or here's another way you can do it. Go online on Google, malignant and benign tumors in the body, and it'll show a picture of a benign tumor, and it'll show a picture of a malignant tumor. A benign tumor looks like a little golf ball or a potato, depending on how big it is. I'm serious, it's weird. It looks really, really unoffending. It's like it looks like a little tumor mass, right? You look at malignant tumor, and it looks like the Black Death.
Ugh.
It looks like bloody sputum on a piece of cloth. It looks disgusting. And you will definitely can tell which one would I want in me if I had a choice between Tweedledee and Tweedledummer. You want Tweedledee. You don't want the malignant tumor, you can see, you're like, I don't want that black tar on my lung.
Yeah.
And you just, you know which one would be worse.
Because it kind of seems like you wouldn't be able to see anything at all because you can't differentiate it. Like, that's how it seemed in my head.
Okay, yeah.
Yeah,
that makes
it's
sense.
backwards. It's
What it looks
backwards.
like.
So that's why we're going through this, because differentiation means the cells of our body, our lung tissue, our bone, our blood, our neural tissue, they're well differentiated. They're all different. They look different under the microscope, and they have different functions. Benign tumors, because they're less offending, they maintain their differentiation because they mimic and stay close to the cells of the body that they're replicating from. Where malignant tumors, they have changed. They are invasively destroying the cells around them, and they're aggressive about it. So they don't make any qualms visually. They look like they're invaders, and they're actively going after the cells around them to take them over and to kill them and to make sure they're the primary cell in the body.
That makes sense.
They
now.
look like invaders.
Yep.
Where well-differentiated cells, they look like nerve cells still. They look like lung cells still. They look like lymphocyte cells. They look like the cells that they're coming from, and they maintain that well-differentiated appearance, just like the rest of the cells in our body do.
Mm-hmm.
Okay, so that one's a little bit weird, and that's why I wanted to spend a little bit of time on that one, because that could be a question on an exam, and they will use the term differentiation, and you could miss it because you're thinking, oh, malignant cells are well-differentiated. They look all the same, and they're mean and nasty, where you have to look back and say, wait a minute, body cells in normal functioning are well-differentiated. They all look different. Bone looks different than blood. It looks different than lungs. It looks different than liver, right? And they're all well-differentiated for the function and job that they do. Malignant cells don't do that. They do one job. That's kill everything around them and want to move around, and they are good at their job, and they look invading.
Okay, good.
Are we good? Okay, cellular cohesiveness. Benign cells, do they stay together or do they break apart?
Stay together.
Yeah, benign cells stay together, and malignant cells have no qualms about breaking into smaller pieces and moving around the body. Okay, sorry, go ahead, please.
So we should say, what's the term for that? Like cell cohesiveness is like stay together, it's like will be unmovable.
They just put stay together for benign, and for malignant they break apart. But that's really what metastasis is.
Yeah, so that's what I think. Like with this, I would think about metastasizing.
Yeah, they're just. The key is time for prayer.
I know.
I know what that is. Allah is God. Muhammad is his prophet. There's one word, one voice. I learned the prayer when I was in Afghanistan.
Yeah. Oh, so you went there.
I do call for prayer, so I know what that is.
Good.
And it absolutely doesn't offend me at all.
Oh my gosh.
Okay. So that's cellular.
Sorry to interrupt, guys.
Okay, growth mode. Okay, which ones grow more aggressively, benign or malignant?
Malignant.
Malignant
are more invasive, so they infiltrate other tissues. So if it starts in the lung, it's not only going to invade the tissues of the lung, it's going to want to invade into the abdomen. It's going to want to invade into the liver, into the kidneys, into the stomach. It's going to want to move. Where benign tumors, if they're tumors from the lung, they'll generally want to stay in the lung. They don't want to go anywhere.
So slow growth and fast growth, that would be. So we can call them like slow and fast, right?
Yep.
So slow. Okay.
And remember, in the body, when you see a benign tumor, it's going to be in a round circular structure that it's going to stay to itself. It's going to be round and circled, and it's going to be encapsulated in a shell, right?
Yeah, encapsulated.
Like a star shape. They have tendrils that start to invade the tissues around them, and they start to swirl in between cells around them, and they start to invade other areas, and they're really good at it. Encapsulated benign tumors don't do that very well. They push against the guys next to them, and that slows down their growth. Okay, growth pattern. Okay, we just talked about benign tumors are encapsulated, and malignant tumors infiltrate other tissues. Okay, growth rate. Benign tumors generally grow slower. and malignant tumors grow more rapidly. And then this is a crazy one. So hormone secretion, which ones secrete more hormones, benign or malignant tumors?
I think it's malignant.
Okay, so that's actually backwards. Benign tumor.
No, sorry. Yeah. I meant to say benign because benign like to act like the normal cells.
Thank
so
you.
they
That
will.
Perfect.
Yes.
Yeah, perfect.
Yeah.
Exactly.
Then
Well,
they have a name for that hormone actually to stimulate the blood. Like
that's called angiogenesis. When the malignant tumors are doing that, that's called angiogenesis.
Okay. 9 will be.
I crashed my Surface Pro, I think, and that's why this isn't working. We're all still friends. Okay, I don't know what the hell's going on. Okay, moving right along. Okay, here we go. So that's that guy. So hormone secretion, benign tumors maintain hormone secretion of the original cell type, and malignant tumors do not. If they're secreting any hormones, their hormones are designed to innervate and invade the tissues around them. They have nothing to do to help the body. They're hurting the body when they do that. Okay, metastasis potential, that's easy. Benign tumors don't metastasize and move, and malignant tumors, they will eventually metastasize and move. And then the last one is tumor mobility. So let's use an example for this one. So, ladies, I know that you're women and stuff, and this is definitely more for you than for men. But when you have a breast tumor and you're doing your breast exam and you guys can find, or a woman finds a lump, if it's fine, will it move around when you touch it and massage it? Will it want to move on its own?
If it's benign?
Yes.
Yeah, because it's in a little capsule, so it's slippery.
Perfect. That is exactly right. It will move on its own to touch and to stimulation. It'll have a certain amount of mobility under your skin and in that tissue, where malignant tumors will be fixed firmly in place. You touch them and massage them, and they will stick where they were at, and they will not want to move. Excellent. Okay, so let's do an electrolyte review. I'm on the third slide. It's electrolyte review unit 2, and it's basically has the spreadsheet or the boxes that talk about the 4 major cations and what they do and where they're at.
Okay.
Okay, y'all with me? Okay, let's quickly go through this. So what are the 4 major cations?
Okay, sodium, potassium, and
magnesium.
Okay. Yeah, sodium.
Potassium.
Yeah, sodium, potassium, and they excite.
Yep.
And then we have magnesium and calcium, and they calm.
Yep, and they calm. Okay, let's go through the numbers. So Ashley, under sodium, what's the normal range for sodium that we're looking for?
135 through 145.
Okay, excellent. And what's the major system in the body that it acts on?
CNS.
So yep, central nervous system, brain and spinal cord. Okay, Zakia, let's do potassium.
Okay.
What's the normal range for potassium, and what system does it act on?
Okay, so it's 3.5 to 5, and it will affect your heart.
Okay, and then calcium?
Oh, calcium will be 8.5 to 10.5, and then will affect the muscles and nerves.
Yep, and then what about magnesium, Ashley?
1.5 to 3, and it affects the smooth muscle.
That is correct. Okay, so do we need to dig down further in these and talk about their function and how they work, like elevated and decreased levels, or can we move on?
Let's talk about magnesium.
What's that?
Magnesium.
Okay, so look at calcium and look at magnesium. Both act on muscle tissue, right?
Yeah.
So when we talk about calcium, when we have elevated levels of calcium, we get muscle weakness. When we have decreased level of calcium or too little, we get tetany or rapid firing, and our muscles don't want to relax. Okay. If you look at magnesium is very similar. So if we have too much magnesium, we can drive ourselves into respiratory failure. And the reason that is because the elevated levels of magnesium keep our smooth muscle from firing correctly. It's like having too much calcium. The magnesium works on those smooth muscles, those receptors, and says, relax, don't stay tight. And so if that's happening, your diaphragm and your intercostal muscles will be so relaxed they won't want to breathe.
Okay. Got
So
it.
what about too little? What about too little magnesium? What does it say there? Can you see the notes?
So everything will be okay, so everything will be like in tetany or like causes, I think everything will be hyper activated.
Yeah. So if you have low levels of magnesium in your smooth muscles, specifically at your lungs, your uterus, your heart, and your intestines, you have what's called hyperreflexia, which means that those muscles will not want to relax. So if in your intestines, your small and large intestines, they're contracted, they don't relax, what's happening to the food in there?
Oh, that is, so you'll get the D.
Yeah, well, you'll get DTRs, which means that you can't relax. But like, for example, if your intestines will not relax, you'll have constipation. Your food will stop moving because they're tight and they won't want to move. Okay? Same with your skeletal muscle.
Wait.
If your arm is tight and it's in tetany, it will not relax. You won't be able to relax your arm and let it straighten back out. And
wait, I thought.
Sorry, go ahead.
So I thought that if you have hyperreflexia, then you will not have C, you will have D. Because I don't want to like raise my voice on those two words, but like you'll have D, right? You'll not have C in your intestine.
You mean constipation or diarrhea?
Yes. I'm just in the library. Can I like shout it?
Well, no. Let me ask you a question. So, if you have tetany, right, in your intestines, that smooth muscle around those vessels, around those pipes, is all contracted and pulling tight.
Okay.
Can food move if that's going on?
Yeah. So I think the food will be like easier to go down. Like it's not because like if that slow rate, then you will have C.
So if you're saying that you have elevated magnesium in your intestines too much, your muscles will be relaxed and you'll be constipated. And if you have too little, then it'll be rapidly moving the food and it won't digest it well and you'll have diarrhea.
Yes.
Okay, well, let's do this then. Ashley, do you want to chime in? Do you have an answer? Do you have an opinion on that? Because I honestly don't know right now. I think Zakiya makes a good point, and I don't know. I'm gonna go look it up, and I think what we'll do is we'll table that and we'll look it up, and when we get together next time, we'll make sure we answer that definitively. We'll go to the book and the notes, and we'll definitively answer that so we all understand it and know it's right.
Okay. So
is that fair?
Yeah.
Yeah. Yes, it's like, let's see. I don't have it here, but there is a chart. Yeah, there is. We have a chart. We have a chart of like low and high because I got confused on this one too because you never know how this will manifest like in body, how that will manifest. Yeah. But like if you have your, let's see, your muscles like doing this, you will not have anything there because they're already irritated. But if they too calm, nothing move. There is no peristalsis.
Like I said, I think your logic makes sense. I'm just not sure right now.
Okay, then
let's look it up, and when we meet again, we'll answer that question.
Okay, good.
I honestly don't know. I thought it was too tight. It didn't let the stuff move. But your logic makes sense now that I think through it. So I'm saying I'm going to look it up.
Okay.
Okay, we're good. For the sake of magnesium, it acts on smooth muscles, lungs, uterus, heart, and intestines. There's an elevated level of magnesium. It causes respiratory failure for sure. And a decreased level of magnesium causes hyperreflexia, which is called DTRs, and they can't relax. Okay, we good?
Yep.
Okay, moving right along. Now we're going to do an acid-base review. So I'm going to bring this up. So we're on slide number 5, I believe, and it has the acid-base set up. So acidosis and alkalosis, respiratory and metabolic, and we'll just go through this. So if you look, Megan wrote this up on the board in class, and I built this for PowerPoint so I'd have it nice and clean. So if we look at respiratory acidosis, the top right hand.
I can't see it.
Oh shoot! Hold on.
Okay. Good now. Yes.
Okay. So if we look at the top right hand corner,
Okay.
Piece of crap. Sorry, I'm cussing at myself. So if you look at the top right corner, which is respiratory alkalosis, which is a pH of 0 to 7, okay, what you have is a decreased level of oxygen in the body with an elevated level of CO2. So let me ask a question. So when would we have a condition, or when would be a time that we'd have decreased levels of oxygen with elevated levels of CO2?
COPD.
So yeah, COPD is a good one. Well, here's another really easy one. Someone's choking me.
Oh yeah.
Someone's physically got their hands around my throat and they're choking me. I'm not bringing oxygen in, and I can't get the CO2 in the body out. So anything that's foreign body airway obstruction, so COPD is a good example. Laryngeal edema is a good example.
So suffocation, maybe?
Yeah, so anytime you're suffocating, that's going to drive you into respiratory acidosis.
Okay.
So let's move over to respiratory alkalosis. Now we're going from pH 7 to 14. That's a basic condition. So when are we going to be with elevated levels of oxygen and decreased levels of CO2?
Okay, it's already said there, hyperventilation.
Yeah, so hypoventilation is a great one. So for example, a young lady in high school who just broke up with her boyfriend and has a big history exam that's going to determine if she gets in college or not, she may hyperventilate to deal with her stress, which means she's blowing off her CO2, giving her elevated levels of oxygen, and that's going to drive her into a respiratory alkalosis condition. So what we need to do is get her to slow down her breathing, deal with her anxiety, and get her to relax a little bit, and then that should return her back to a normal condition. Her alkalosis should start to diminish as the oxygen levels reduced and the CO levels gets back to normal. It should bring her back to her normal balance. Okay, number 5 on that list though is a really interesting one. Can you guys see number 5 on that box? What's number 5 say?
Ventilators.
So yeah, now we're in a situation where manually ventilating oxygen into somebody. So say in surgery, right? We put them under and we manually ventilate oxygen into them. If we're not careful, that will drive them into respiratory alkalosis. Because in addition to having CO2 levels high and CO2 levels being low, we're also blowing off a third type of gas. Do you remember the third respiratory gas in class we talked about?
Nitrogen.
Nitrogen, yep. It's going to blow off nitrogen, and it's going to throw off the oxygen CO2 respiration cycle. Because nitrogen plays a role in that, and that will also be gone when we're manually ventilating somebody.
Mm-hmm.
Okay, we have that stupid little machine that makes them suck in for a long time to pass that little bulb in that tube, and that reseats their nitrogen levels. So that's a way that we manually reseat that nitrogen and get the ventilation, our manual ventilation out of them, and get that oxygen CO2 level back to normal with the nitrogen firmly in place back in their lungs.
Yeah, so the only thing is like with this, it's like when we have it in a question where, let's see, if somebody was like hyperventilated, how his like gases would like count will be look like. They will give you like pH number, like either alkalosis or acidosis, and then we'll give you like CO2 number, and we'll give you like the bicarbonate number. It's just like throw me off. Like I cannot determine what the problem will be.
Let's play a little game. So Ashley, you want to play a little game with this?
I don't know if anybody else has the same problem. Like if you have renal like dysfunction, anything that related to kidney, you always know is acidosis one, no matter what. It's like will be metabolic acidosis, and like pH should be low. The pH will be low, and
ask this question. So if they're in renal failure or kidney failure, are they always in acidosis? Aren't there 3 steps in that process? There's uncompensated, partially compensated, and compensated. So they can be in renal failure and not be entirely in metabolic acidosis because they can be recovering. Their body can be recovering from it. So remember, there's more than just, it can't just be, oh, they're in renal failure, they're always going to be in metabolic acidosis in that question. That question can give you values where they're in compensated renal failure. In which case, what are their blood gases going to look like if they're in compensated renal failure?
So you will see, okay, so maybe you will see the pH normal, but
normal.
And then CO2 also will be normal, but you will have low bicarb.
That's not entirely true, because in compensated at the very end, pH is normal. What are the other two values doing to get into normal? Both the CO2 and the bicarb are working to keep them in a normal pH. The other two values are both adjusted, aren't they, in compensated?
Okay, so they need to look normal?
No, what I'm saying is it'd be what you're asking. I think what you're saying is it'd be really easy to memorize a set thing about renal failure, a set thing about hyperventilation. What I'm telling you is that this is more fluid than that. There is a balance, right? So what's the normal balance for pH in the body? What's the balance that we're trying to reach to be homeostasis and normal function? What's the balance for pH?
Yeah, it should be between 35 to 45.
Yeah, 7.35 to 7.45, correct?
Yes,
Anytime they go too high or too low, the body is going to do something to try to bring it back.
Yes.
Okay, the body can choose to do basic bicarb, which would be metabolic, or it can choose to fluctuate O2 and CO2, which is on the respiratory side. The body can also choose to vomit and vomit out acid out the front. So what I'm saying is it's not one set thing. There are multiple things going on that can adjust pH. And we have to just remember, okay, listen, an uncompensated person, someone's uncompensated, and they're uncompensated for ventilation. Okay, they're hyperventilating and they're uncompensated. They're at the very beginning of it. The girl just started hyperventilating. So what are her blood gases going to look like if she's uncompensated? I think what you're saying is true for totally uncompensated. We walk up to a patient who's in the very first stage of acid-based offset, and that would be true. So what would someone's blood gases look like if they're hyperventilating?
So they will have first the pH will be high.
So pick a number that's high.
Okay, let's see. That will be like above the 42. Above 42. Let's say 50. pH is 50. So CO2 will be very low.
So bam, they're 7.50 pH, right?
Yes.
Okay,
and then you have
they're in alkalosis something, right?
Yes.
They're alkalosis something. So what are the rules that drive somebody into respiratory alkalosis? What does one of the other values have to be doing?
Okay, so CO2 will be low if you hyperventilate it, and then you will have, I don't know about the bicarb, but I think bicarb will be normal.
So remember, in order for it to be compensated, uncompensated, pH will be high, 7.50, correct? One other value between bicarb and CO2 has to be pointing in the opposite direction or down, right, for it to be respiratory.
Okay, so let's see, if we take CO2 as low, like will be, let's see, 22.
Yes. So that's a situation. So let me help you out then. So I've got a patient who is in alkalosis 7.50, right? They're 7.50 is their pH. Their CO2 right now, their CO2 is sitting at let's say 37, and their bicarb is sitting at 18. Under the rules that we learned in class, are they metabolic or are they respiratory at that point?
So its look is uncompensated, but I cannot decide.
Don't deal with compensated, not compensated yet. The values that they give you are pH is 7.50, partial pressure of CO2 is 37, and their bicarbonate, HCO3, is at 18.
So we have metabolic alkalosis.
Okay, they're in alkalosis. There are two rules that drive if it's metabolic or if it's respiratory. Do you remember the two rules?
Huh.
So Megan and Tana went through this with us, and they said, "Hey, listen, the rules are if the arrows point in the same direction." Let me look the rules up really quickly. So if if I have elevated levels of
Okay.
pH, I must have an arrow pointing in the same direction to be metabolic. Okay. If I have respiratory, I got the arrows pointing in the wrong direction. So at pH high, carbon dioxide is normal. It's in a normal range, and bicarbonate is low.
Wait, let me write this down. So you said CO2 will be 37 as a, and then bicarb.
Attention, the library is closing in 15 minutes.
Okay, understand. Okay.
We're good.
So okay, so respiratory. So if that will be respiratory, so like so the arrows should be the same side. That's mean like the error with CO2 and the pH, or which the two ones that you said.
You're getting caught up every time you see high bicarbonate different. High or low bicarbonate is metabolic, right?
Yeah.
That's not it. That is not the rule. The rule is if I have one arrow going one direction and I have a different arrow and a different value going the same direction, it's metabolic. If I have so starting with pH, if pH is going high and one of the values is going high with it, it's metabolic. If pH is high and one of the other values is too low or pointing down, it's respiratory. And it doesn't matter if it's CO2 or bicarbonate. Okay?
Oh,
Everyone is grabbing onto that saying, oh, if it's bicarbonate, it's metabolic. That's not true. You'll miss it.
That's what I think.
Yep.
Okay.
People have grabbed on the base going out the butt and that being bicarbonate and that throwing us off. That is only true in metabolic acidosis because bicarbonate is a base and you're pooping it out, leaving an elevated a level of stomach acid in the body, driving you to acidosis. Okay? But at the end of the day, let me give you another example. Okay? So now I've got a situation where the person's pH is 7.
Chris,
yeah.
Just a second.
Yeah.
ماما. الو.
Ashley, you there?
اسمع أنا قاعدة في الكلية. تقدر تجي؟
Are you following?
الساعة 6 قال بسكر هنا. كلم زهرة بقى خليتي تاخذني يقول لها المكتب نسيت بسكر الساعة 6. Yeah.
Hey Ashley, are you following the discussion we're having?
Yep.
Yes.
Okay, so are you tracking where I'm going with this?
Yes.
Zakia's not the only one who's doing this, okay? People are grabbing onto carbon dioxide and bicarbonate to drive respiratory and metabolic. Yes, there is a pattern that those gases and bicarbonate do that thing, but that is just not the rule. The rule is what? What's the rule that drives metabolic and respiratory?
Like when we're talking about the arrows?
Yeah.
This is how I remember it. I see, like, if the arrows are going different directions, I think of it as chaos and, like, you can't breathe, so it's an emergency, so it's respiratory. And then metabolic, if it's the same, then it's metabolic, if they're going the same direction. That's how I remember it. I don't know.
That's it. Perfect, okay? Again, I just want to make sure that people are that's why we're reviewing this, because I have seen people missing questions on this because they get caught up in CO2 and O2 and partial and blood pulse ox and all this stuff, and they don't remember the rule, which is same direction, metabolic, opposite direction arrows, respiratory.
Yeah, I pretty much just pay attention to the
arrows
pH and the CO2 to get my answer for all of that.
Okay, and remember, the 3 steps of this is compensated, uncompensated, partially compensated, uncompensated. And the way that I remember these the easiest is that uncompensated, the pH is off. The pH is high or low. In compensated, pH is in the normal range again. And then partially compensated, all the values are in flux because the body's trying to repair and move around.
Okay,
that's
so
the most confusing thing to me.
Yeah. Yeah, so to close this, so we can move on. So we have, like, if the pH is high, and then one of the other two will be low or high, then that will be a respiratory issue.
No. If pH is pointing up, it's too high. One of the other arrows, bicarbonate or CO2, has to be pointing high for it to be metabolic. It has to be elevated to be metabolic. If pH is high and one of the other values, CO2 and metabolic, one of their values is pointing down in the opposite direction, that's respiratory. That's it.
Okay.
It's got nothing to do with bicarbonate or CO2. It's just if both arrows are pointing in one direction, the same direction, too high or too low together, pH is pointing one direction, one of their value is pointing the same direction, that's respiratory. If pH is pointing one direction and one of their values is in the opposite direction of pH, it's metabolic.
Okay, one of the others pointing different direction.
Before, Zakiya, I'm going to give you that example before. So write it down. Write this down as I say it. pH is at 7.50. Is that high or low?
High.
Okay, so the arrow is pointing up, right?
Yep.
Okay. Then my partial pressure, PaCO2, is at 37. Is that high, low, or normal?
Oh, this is normal.
That's normal. Okay. Now I've got my bicarbonate, HCO3, and HCO3 is at 18. Is that high, low, or normal?
This is 18 is low.
Okay. So which way is pH pointing?
It's high or up.
Which way is bicarbonate pointing?
Down.
Okay. So what is that? Is that respiratory or metabolic?
So pH is high, and then one of the other will be in a different direction. That will be metabolic.
No, that's respiratory.
Oh my gosh. Okay.
It's respiratory.
Respiratory. Okay.
Are you ready?
I write it wrong.
Keep that example right there. Respiratory. Here you go. You ready?
Yep.
pH is 7.50. Partial pressure of CO2, PaCO2 is 37 again.
Okay.
And bicarbonate now. Bicarbonate is let's say bicarbonate's 28.
Okay.
Is that high, low? So they're the same except for the last one, right? Is that high, low, or normal?
This is high.
Okay. So is that respiratory or metabolic?
Okay. I think this is the same direction. This should be metabolic.
There we go. That's the rule.
Okay.
And it has nothing to do with being CO2 or bicarbonate. It has to do with what direction they're pointing.
So even though if the CO2 was like out of range, like if CO2 was 50, like the same pH, let's see. So, and the CO2, the CO3 was 18, so it will be low. It still will stay still metabolic.
Okay, listen. Here's your example. 7.50 pH.
Okay.
My CO2 is now 52.
Okay.
And my bicarbonate is 18.
52. And bicarbonate is 18. Respiratory.
Why?
Because it's just the bicarb and the pH is in a different direction.
There you go. That's it. You got it.
Okay. Yes. Okay. Thank you.
Pointing opposite of pH, it is respiratory. If the arrows are all pointing the same direction as pH, it's metabolic. That's it. That's the rule.
Okay, so even it's like pH will be high or low, and the metabolic will be in the same direction, I will know that's metabolic. If they different direction, that will be respiratory, no matter what.
Yep, that's it.
Okay, thank you.
That. I think it was worth it.
Yeah.
Okay, let's go through Glasgow coma, and we'll be done. So guys,
okay.
I'm on slide number 12, Glasgow coma scale. So I skipped all the definitions, okay? Are we all there?
Yeah.
Yep.
Okay, so what is the Glasgow coma scale, Ashley?
How
And you can use your own
Not
words.
crazy a person is? Is
Yeah,
that
it's a way to assess neurologic function.
competence? Yeah.
And so, yeah, we could use Glasgow Coma Scale to assess a crazy person.
Okay.
Absolutely, we could use it to assess a crazy person. But we can also use it to assess someone who's been in trauma. Someone's been in a car accident. We're assuming they were normal before they crashed their car. And now we're doing a neurologic test with Glasgow Coma to determine
Library
how
will be
much
closing
focus
in
function
5
they
minutes.
have.
Please start exiting the building. Run ready to do work as
Okay,
soon as possible.
so we do it for trauma, vascular injury, infections, hypoxia, and metabolic disorders, specifically dealing with renal function, liver, hypoglycemia, and hyperglycemia, specifically with ketoacidosis. Okay, we good? Okay, moving
Would you
right
repeat
along.
the last sentence?
So
Oh.
and then remember, it's metabolic injuries, liver, kidney, hypoglycemia, hyperglycemia.
Okay.
Okay, then moving along. What
Yeah.
are the 3 areas of the Glasgow Coma Scale? What are the 3 areas of the body that we assess?
Okay, motor and verbal and eye?
Yep.
No.
Eyes, verbal, motor.
Okay, eyes, verbal, motor. Yep.
So how many different levels are there in eyes, Ashley?
4.
Okay, 4. How many different levels are there in verbal, Zakia?
I think is that 5 or 6?
It's 5.
I think
And the last one,
five,
motor has 6. Okay. The
Okay.
easiest thing to remember is if you're at the top of the scale of that particular function, it's normal. So eyes, number 4 is normal. Number 1 is none on all of them. So verbal, number 5 is normal. 1 is none. Motor, if they're fully comprehending in motor, they follow all your commands and can move and take care of themselves, it's 6. If it's not, there's no motor function at all, it's 1. And then we have the stage in the middle.
And then do you add them up from each?
Yes, and then you'd add them up from each one. So let's use an example. So if I have eyes and they're alerted to my voice, that's a 3, right? So eyes would be 3.
Yeah.
And what if the person verbally is using inappropriate words? What's that score going to be?
A 3.
3. And then what if they follow all my commands appropriately for motor? What if hey Ashley, can you point your body to where you're hurt, and you point to your arm and there's a broken arm there, and you point
to
the
command.
right? That would be
To
what?
command. To command.
Yeah, they would be following my commands appropriately. So that would be a 6. So what's 6 plus 3?
9.
And what's 9 plus 3?
12.
So their Glasgow Coma Scale would be 12. And if we look at the scale that goes with this, that just means they had a mild head injury. They're mild. They get their bell rung, but it's mild at this point.
Okay.
Okay. Let's see here. Okay. So let's hit stroke really quick. The 4 areas of stroke to recognize a stroke. It's an acronym called FAST.
Yep.
Face,
Talk to you later.
arm, speech, and time. Face, arm, speech, and time. Okay, under face, what am I looking for under facial?
Drooping.
Yep, if they're having a stroke, they're going to have drooping on one side. Arms, what are you looking for in the arms?
If they can equally hold them up at the same time.
Perfect. Speech?
Slurring.
Yep, drunk man's disease.
Yeah.
And time. How much time do we have after a stroke starts to intervene?
3 hours.
3 hours. And only one kind of stroke we can intervene in 3 hours. Which one is it?
The embolism?
Hemorrhagic.
Oh.
Okay. If we go and we give them those drugs and they're having a hemorrhage in their brain, it will kill them. Do not give the anticoagulant drugs to someone who's having a bleeding brain injury. But we can give it for thrombus and embolus.
Okay.
Hey, we good?
We're good.
Yeah, at 6 o'clock. I'm gonna get back on at 9:30.
Okay.
So sorry that review at the beginning took so long, guys.
It's all good.
Okay.
I think Zakita left already.
Okay, so it's just you and me.
Yep.
Is that your babies, Ashley?
Yeah, they're so loud.
It's okay. I was just like, man, I hear kids.
Yeah, it's my kids.
That's okay. No problem. If it's not somebody's kids, it's somebody answering their phone. If it's not somebody answering their phone, it's somebody making their dinner.
Yeah.
And then just we inherit some of that. Well, cool. So listen, Ashley, if you didn't get what you needed, like because we did a lot of review, just go ahead and go through the slide deck. Now that you have it up, just look through it.
Yeah.
And
The
it kind
only
of
stuff I'm
drives the discussion.
iffy on is like the stuff they didn't cover in class.
What was that?
I'm just iffy on the stuff they didn't cover in class because we ran.
I started covering the stuff at the end. So if you go down to number 8, injuries, you'll notice that stuff that they didn't cover.
Mm-hmm.
And then the vocabulary practice that they have on the lecture, I've added that to this at the very end.
Okay.
So go ahead and try the vocabulary practice and see how you do.
Okay.
You good?
Yeah, we're good.
And I'm going to keep building this up, and I'm doing meningitis right now. I'm building stuff for meningitis right now, which is something we didn't cover in class.
Okay.
Okay, we good?
Yeah.
Okay. I will talk to you when you get on again.
Okay, sounds good.
Later. Bye.
Bye.
Hello? Yeah, we're going to be done.